Good evening, everyone, and welcome. Tonight, Milford Regional Urogynecologist Dr. Diego Illanes will discuss the various types of incontinence, their causes, and the latest treatments available. Before we get started, just a few things to note. This webinar is being recorded. The raise hand function will be disabled, and Dr. Illanes will take questions at the end of the presentation. You may type in your question at any time through the Q&A icon on the bottom of your screen, and we'll try to get to as many questions as possible. Now I'd like to introduce tonight's speaker. Dr. Illanes is a graduate of the Universidad Católica de Córdoba in Cordoba, Argentina. He interned in obstetrics and gynecology at Albany Medical College in New York, completed his residency in obstetrics and gynecology and a fellowship in female pelvic medicine and reconstructive surgery at the University of Massachusetts Medical School. Dr. Illanes is board certified in female pelvic medicine and reconstructive surgery and obstetrics and gynecology. Furthermore, he is the assistant professor of obstetrics and gynecology at Tufts University School of Medicine, and he is fluent in both Spanish and Portuguese. It's now my pleasure to hand over the webinar to Dr. Illanes.
Thank you, Michelle, and thank you, Tricia. Good evening, everyone. I'm just going to share the screen here. You can see it, right? All right, so the discussion will be a very practical guide about a very common problem that has to be recognized as a problem in women, as it is urinary incontinence, which is the involuntary loss of enough urine. So these are the key words here. It's enough urine to cause a problem, either social or hygienic, but very importantly in alteration in the quality of the life. So what is a requirement? First, to be continent, not to have this. It requires mentation, so patients needs to be aware of it. Motivation and mobility, so needs to be able to go to the toilet and utilize it. Muscle strength and manual dexterity, but those are the common musculoskeletal basic needs. And then overall, a very properly functioning urinary tract, which is, we will review, is the bladder, the storage unit, and the urethra, a little tiny tube for where the urine drains out from the bladder to the outside. This is probably the most important slide of the presentation of the webinar, that incontinence is not a normal part of aging, and it's something that it needs to be passed along among families and friends to say that is not normal. If this happens in a way that alters the quality of life, it is not normal. It could be something very transient. For example, like a urinary tract infection can give a patient urgency and incontinence, or it could be something very chronic that it doesn't go away after an insult that we call, like, for example, a UTI or irritation of the bladder. So what could also be transient? A patient who starts medication, sometimes, for example, the water pill or diuretics can increase the urgency and the production of urine. As I mentioned, their infection, or a patient who had a restricted mobility, like a broken hip or a broken bone. Dietary, many times some bladder irritants can cause the incontinence. The inability to empty the bowel. The pelvis is a very small area in the body that it could only allow one thing at a time. I say it's either the bladder, the bowel, or the uterus and the vagina. So if one is altered, it can alter the other. For example, a chronic constipation, when there is no room inside that small pelvis, it could cause incontinence. Inflammation, like anything that it causes swelling inside the pelvis or the outside organs, like in the vulva or the vagina. And psychological, patients who are not aware of a psychiatric problem can also leak urine. A lot of names here about what causes. Essentially, the main mechanism is very simple. If we consider the bladder as a storage receptacle that allows a liquid to go in, and it has an exit point that is controlled by a sphincter. So anything that alters the sphincter, many medications, blood pressure medications, for example, can alter the tone of the sphincter and allow urine to escape. Some diuretic, as I mentioned before, not necessarily what the primary care prescribes, but it could be as simple as caffeine or beer. And alcohol is a diuretic in the brain that can increase the production of water through the kidneys into the bladder. Common things in our diet that we think that they are just okay, it's healthy, but it can increase either the urinary production or irritates the bladder, like artificial sweeteners or juices like lemon or acidic juices, and anything that has carbonated beverages like sodas, for example. A lot of the heart medications like calcium channel blockers or antidepressants can cause alterations of the sphincter of this bag that it has a valve exit. So what do we do with patients like this? What happens, just to give an idea to the public, what happens when your primary care doctor refers you to see a urogynecologist, which is essentially a provider who has done residency in women's health in OBGYN, and then a subspecialty in a pelvic floor that we call it. The name has changed. It has a very long name, female pelvic medicine and reconstructive surgery, to just urogynecology, which is a combination of bladder and bowel and gynecology, or the female pelvic organs. So a patient comes in, and we take a history. Typically, there is a questionnaire that the patient fills out that it talks about bladder and bowel habits. And then a pelvic examination most of the time happens in the office. It doesn't have to, but we inquire about the bladder function, and we call that a voiding diary. So a patient will either complete that at home before coming or after seeing us, but sometimes we help them analyze what happens to the bladder during the day when they're not there. Essentially, how many times they urinate, if they have urgency, if they have frequency. Always the questions go back to quality of life. And like, to me, urinating 2 or 3 times a day, it doesn't alter my quality of life. But if I go more than 10, it could really impact my day-to-day activity. Then in some patients, we may ask for an urinalysis, or just testing the urine for infection, for example. And then we measure how they void and how much is left after they urinate, and that's called post-void residual. So what is the purpose of the voiding diary? It's essentially learning what happens in 24 hours when we are not there. Obviously, we cannot be with the patient all the time, and there is not such a device that it can track it like a Holter monitor for the heart. We rely on the patient telling us how many times they go, how much they drink, and how many accidents or urinary leakage or episodes they have during the day. And also importantly, what happens when they were doing or when they were leaking, were they exercising, or were they just doing nothing, just having urgency. So then all this information helps us determine what happens here. Is it functional, or meaning is probably the diet, they're drinking too much, or they're drinking irritants, or something is wrong in the urinary tract, like, for example, the muscle doesn't work well, or the bladder muscle works too much, what we call overactive muscle or overactive bladder. So I was mentioning before, they're simple units. So it's a bag with an exit pipe, so to speak. So we are talking always, when we refer to urinary incontinence, and storage problems or releases problems. So the most common ones are store problem in women. So it's urgency when it's a bladder problem, or is stress incontinence when is a urethral problem, or the urethra meaning that tube where the urine empties is about 2 inches long, and it has a muscle that is about a couple of millimeters long or strong. So the urge incontinence, going back again, there are two main types. One is urgency, the other is stress. Urge incontinence is the gotta go now. I will not make it to the bathroom. It's not enough time to pull down my pants and sit in the toilet and urine starts coming. It's also the one refers as a mapping or the key in the hole sign. Patients typically will drive their car, they get in the driveway, the brain knows that they're in the driveway, and the bladder starts activating and they leak. So different names for this urge incontinence, which is the main name, are detrusor instability. Detrusor is the bladder muscle. It's that big muscle like a bag. Detrusor hyperactivity or detrusor overactivity. The most common etiology of this is, believe it or not, the diet, either bladder irritants or the amount of fluid that the patients will drink during the day. The problem typically occurs day and night, so they wake up at night as well several times, and in many occasions interferes with the quality of their sleep. And then the other big one, so when we have urge incontinence in one side and we have stress incontinence on the other side, stress incontinence is the leakage of small amount or sometimes large amounts of urine with the increased pressure in the abdomen. That's typically happen with one coughs or sneeze or laughs. Anything that increases the pressure inside the abdomen and pushes the urine out through that urethra, that's stress incontinence. Neurogenic overflow, there are other conditions that they're not very common, but for example, in multiple sclerosis can cause an alteration of that reservoir and the way it drains out and the way it squeezes, like spinal cord injuries or after motor vehicle accidents sometimes occurs. But it also happens days and nights, and those patients are not, they don't feel the sensation of a full bladder. That's why the urine just leaks out because of overflows. This is typically in men. We don't see overflow urine in women because women don't have a prostate. So, and the urethra in men is much longer. It has way more reasons or length, actually, anatomy, to cause the overflow. So how do we manage this? What do we tell patients? When we complete that workup that we saw initially, we tell patients behavioral modification is key. It is very well studied, and we see this in the day-to-day practice. Sometimes just changing what we drink or what we eat is enough. So decreasing acidic food like tomato sauces for some patients, or decreasing the caffeine intake or the sodas intakes. I had a patient the other day that just by telling her she cannot drink 3 cans of Diet Pepsi a day and complain of leakage of urine, she changed that. She went just to water or juice, and it got better, 50% on her own without medications. Then exercises is another. We recommend patients to start on their own. There was a very famous physiotherapist named Dr. Kegel who coined the name of the Kegel exercises, essentially training the pelvic muscles to interrupt the urine flow in a way to gain control. So we teach the patients to do exercises, and if they cannot do them or they don't see improvement, we could refer them to pelvic floor physical therapists, which were specialized people who understand these muscles well. We can try medication. There are 2 types of medications for the urge component, mainly. They gotta go now. Some of them very old, that essential antispasmodic, and now some new medications that they can help the bladder get more urine in before it starts having the contractions or the squeezing. And if the above fails or the patient is significantly altered by the problem, is surgical correction. And surgery these days for the bladder are not what it used to be. These are day surgery, simple procedures overall. We teach the patient how to retrain their bladder, essentially trying to void every 3 hours, always at the same time during the day. It's essentially the potty training, what we were taught when we were infant or children, to be able to train spinal cord reflexes of what a full bladder should feel and when the brain should feel that full bladder. So it's every 3 hours to 3 to 4 hours during the day, always at the same time. If the patient does this during the day for about 2 weeks, they could potentially experience an improvement more than 50% of the times. It does not work at night, so at night they're supposed to sleep. So it's only retraining during the day. Pelvic muscle rehabilitation, a lot of patients decide to get referred by either the primary care physician, which is very appropriate, or by us, the urogynecologist, to pelvic floor PT. We have a really great group at Milford Regional. 2 of them are in Northbridge, 3 or 4 of them are in our other location in Milford. And all across the state, there are more and more of this highly skilled professional that can teach the patient how to train a group of muscles that they cannot see or feel, like the Kegel muscles, or the name is levator muscles, which essentially is a plate of thin muscles that closes the pelvis from the bottom. They use different techniques to teach the patients where they are, how to squeeze them, how to control the bladder. Sometimes they even use biofeedback. They put tiny little olives inside, and the patients are able to see on a screen if they are exercising the right group of muscles. Surgical management for the stress component. Remember, stress is the one that when you leak, when you cough, sneeze, or laugh, or exercise, or running marathon. So the major 2 are listed there, the mid-urethral sling or the bulking injections. They both tend to do the same, which is restricting the outflow of that urethra. So preventing the leakage by either sort of kinking a little bit the urethra with the sling, which is a hammock that it goes right under, or caulking the inside of that little tube with the gelatinous solutions that decreases the inner aspect of it. So by closing the inner aspect of it, it prevents the urine to escape. The sling that not necessarily needs to be made of plastic. It can be made by the patient's own tissue. And then there is very other advanced all procedures like Birch mentioned there, but we don't do those anymore because they're too morbid, and everything else is solved 95% of the time by the first 2 there, the sling or the bulking. Now the treatment for the urge, the other one. Remember, there are 2. One is stress, the other is urge. They gotta go now. I was mentioning the 2 types of medications is anticholinergic agents. Those are the typical names. Oxybutynin is the oldest one. It is an antispasmodic, so patients do experience constipation and dry mouth with them, all at different degrees. Very recently, the FDA declared that a lot of these medications for the bladder has something to do with increasing or exacerbating dementia, for which we are inclined now to call the other group here, the beta-3 adrenergics, in particular, there are only 2 in the market, as a first-line treatment. Especially in the elderly, we tend to go for those instead of the antispasmodic, the old traditional ones. If the drugs fails, the pills fail, and the diet modification and the behavioral modification fails to control the urge incontinence, then there are essentially 3 advanced treatment options. One is Botox injections in the bladder, which is an outpatient procedure. It can be done with or without anesthesia. And then the second one is sacral neuromodulation, which is what was published on the recent magazine that many patients were able to read, is like a pacemaker to that pelvic floor. It regulates the impulses of the nerves in the bladder and the bowel and kind of resets those reflexes through the spinal cord up to the brain and back. It can be done centrally, so from the sacrum, from the tailbone down into the bladder, or it can be done in the opposite direction, from the feet up. So some patients cannot have this type of advanced procedures. We can utilize the same nerves in their ankle like sort of like acupuncture, and stimulate the nerves in the opposite direction. So from the feet up to the bladder. It's called peripheral tibial nerve stimulation. Some new technologies coming that where those tibial nerve stimulation will be implantable devices that it can be placed into the patient's ankle in an outpatient setting as well. So believe it or not, that's essentially urinary incontinence in women in 20 minutes. Now, Michelle, I will happy to open the forum for questions.
Thank you so much, Dr. Illanes. We do have a couple of questions. One was, if you are prescribed a medication for incontinence, are you typically on that medication for life then?
That's a really great question. Not necessarily. Why I prescribe it sometimes just for 3 months. I think and I tell patients any interventions that I could do is only 50% of the treatment, because I do believe that the other 50% is what they do with their behavioral modification. So initially the plan should be 90 days. Let's work together on this. They can decrease the bladder irritant, retrain their bladder. The medication will help them to boost that, to achieve that satisfaction of an improvement in the quality of life. And after 3 months, we could talk about decreasing or skipping doses if they can get rid of it. There are some patients, however, depending on their condition, sometimes the bladder has a problem that needs the medication for life. But most of the time, we don't know what causes it. Three quarters of the time, we don't know what caused the urgency or the overactive bladder. So 75% of the time, we just trial the drugs for 3 months.
Thank you. Another question I had was, what are the side effects to the Botox bladder injections?
Another good question. The major are two, and is because it's a muscle, it essentially causes a paralysis of the muscles of the bladder. That means that it prevents the full contraction of the bladder, so those bladders may not empty. It happens in 1 out of 10 patients that may not be able to empty completely. So a bladder that it does not empty completely every time, it tends to have a problem getting rid of bacteria that they could be present in the urine. And if the bladder cannot flush out the bacteria, then develops urinary tract infection. So it's a long answer to say two major ones that happens 1 in 10 times is retention, so unable to empty well, and urinary tract infection. The good news is that they're temporary, so it usually goes away by 8 to 9 weeks. Patients start experiencing that they start emptying well because their immune system gets rid of the toxin, basically.
Thank you. Another question is, what is the recovery period for from the surgery for stress incontinence?
A good question as well. This has evolved significantly. We used to admit patients in the hospital. It was a 1 or 2 days overnight admissions and nothing. They couldn't exercise for about 6 to 8 weeks. The recovery time now, there is no restriction. The only restriction is nothing in the vagina, because that's where the sling is placed and there are stitches there. But overall, they are able to resume normal activities the next day. It's like a colonoscopy. Same anesthesia as a colonoscopy, and they go back to normal activities the next day.
Thank you. And the last question I have is, are there any other lifestyle changes I can do besides diet and exercise to help reduce my incontinence?
If it's purely the urge incontinence, so they got to go all the time, the 3 pillars are that behavioral modification, retraining the bladder, making sure that the bladder learns that every time urinates at the same time. Another is making sure to stop drinking fluids after 6 p.m. If one is thirsty after 6 p.m., it could do ice chips, but the idea is to prevent the bladder from getting too full at night when we're sleeping, for example, because it gets too distended. I always use the analogy with my patients that the bladder is like a one of those latex balloons. The more air you put in, when you let the air out, the balloon is all wrinkly and it kind of, it looks, compliance is the name for that elasticity. But if you put little air and then let go, little air and let go, the quality of that latex looks always good. It's never wrinkly. So the same thing happens to the bladder. So in other words, emptying regularly will help prevent the urge incontinence.
Thank you. That's all I have for questions right now that I can see. So I would like to thank Dr. Illanes again for this wonderful presentation. It was very informative. And thank all the attendees for coming. And I hope everybody has a safe and wonderful evening.
Thank you, everybody. Have a good one.
Thank
Thank you,
you.
Michelle and Tricia.